Hello, everyone. I'm really excited to kick off this webinar on helping our elders with their incontinence management and getting a good night's sleep. This webinar has been done in partnership with CINI. They have a beautiful relationship, as does Greenhouse, with Dr. Rosemary Laird, who's a phenomenal geriatrician and has done great education for our groups before. Additionally, we have Kristen Drago joining us. She is a guide at the John Knox Village Greenhouse Homes. So I'll turn it over to you, Dr. Laird.
Great. Oh, Carol, thank you so much. It is really always a pleasure to talk with you and with all of your members. I'm a big proponent of patient-centered care. So I, first of all, just thank all of you in general for your interest in making the experience in your care settings better for seniors and your residents, as well as some particular interest, I hope, in today's topic. I think that if you think about yourself, getting a good night's rest is sort of the basis for having a good next day, right? We blame everything that goes wrong in the day on what happened last night often. And so I think we sometimes lose track of that, quite honestly, in the care of our residents. We lose track of that importance of sleep. And so I was just glad when this topic was put out and we decided to talk about this. I think it doesn't get probably enough discussion. So I'm thrilled to be able to talk about this with you today. So Amber is going to help me with my slide movements. So we're ready, Amber. We're going to go and just look a little bit at the next slide that's going to talk about how we're going to structure the discussion today. And there'll be some time at the end for questions, I'm quite sure. So let us keep track of those. We're going to start by talking about, what's the big deal about sleep? Why does it impact your day and your general health? And I'm going to propose, a little bit bold of me perhaps, that sleep might be appropriate as the next vital sign for all of us to start thinking about collecting information on just a little bit more regularly. So we'll see what you think of my arguments after we're done. We'll talk a little bit then about some of the common changes that happen during our aging process to both sleep, and then we're going to zero in, as Carol mentioned, on sleep and the relationship of our urinary tract habits. And those two things are going to be our key focus today. So we're going to talk about how aging impacts that. We'll talk about how illness impacts that, what that does to us and our elders on a day-to-day basis. And then I promise, after some of the bad news about what happens to our bodies as we age relative to sleep and our urinary habits, I promise we'll get to some solutions and some strategies that we can take. Because the exciting thing about the work I've been doing with the team from CINI and just exploring these topics about urinary incontinence is it's a bit of a whole new world out there with respect to what we know about how we can help people with urinary incontinence. It's not the sort of get a diaper and put it on that person and be done with it. No, that is prohibited behavior in my book. Even that word is prohibited. And we really want to understand what are the appropriate management for individuals with urinary tract issues, especially when they impact sleep, is going to be what we focus on today. So Amber, let's go ahead and move into the next slide, because this is where we're going to be jumping into sleep. So why do we sleep? What is it about sleep that is so important? Now, anybody a runner out there? Now, I'm asking, but you don't have to answer, but any of the people who are runners, maybe you've done a training for a marathon or that sort of thing, you know that every few days, and I'm not a runner, so I'm taking information of what I've been told, every few days, it's important to rest. And you're doing that so that there's a certain amount of repair and growth that can go on with respect to muscles and tendons and bones that are needed for you to be a good runner. Well, the same is true of all of us with respect to sleep. Sleep is when our body does key kind of maintenance in the areas of repair and growth. As we get older, the need, all of us are getting older, right? And we all probably know that the need for the care and maintenance of the older body is that much more critical than even the care and maintenance of the younger body. You can get away with a lot when you're younger than you can when you're older, and sleep deprivation is no different. The next slide, Amber. This is really the basis of why I say it should be a new vital sign. And that is because without that constant repair and growth cycle being available, and I'm talking about repair at the cellular level, at the tissue levels, again, muscles, bones, tendons, joint spaces, all of it. There's information about how the neurons go through cycles of repair and growth during sleep phases. And all of that is critical to the overall function of the body in the daytime. So we've got sleep issues that happen in the overnight hours, and we'll get to that. But the important thing from all of us who are clinically focused, we've not got to understand that they also carry over, and of course our days don't stop, right? They carry over into the daytime. And things that impact sleep are going to impact abilities that are physical, things like your activity level, your appetite, so your interest in taking a certain amount of nutrition in, your immune function. I didn't mention that earlier, but that's another aspect that has certain cycles of repair and growth to the immune, to our blood system, hematologic system, that happen at night. We know that now. So all of that, let alone mood and our cycles of emotional stability or stress, all of that is impacted by what happens at night, impacts into the day. If we have a bad night, potentially going to have a bad day. And what that can do to us over a chronic occurrence, if it's happening over and over, is really the cause for concern here. Next slide, please. So I hope I've convinced you somewhat about how vital sleep is, and maybe you'll agree that that could be something that you may want to start taking more notice of, how much sleep your residents are getting. We're going to talk next about what actually does happen. What is that age-related change of sleep? And then we'll also start layering on issues about the urinary tract system. So next slide, please. So sleep is good when you can get it. Yes, 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 it is. Now, what is normal sleep? And this is actually one of the places I love to be talking to a patient-centered crowd, because you guys know when I say normal, that's going to be one number, and you see it here, 7 to 9 hours. But you're also going to know that you need to talk to Mr. A and Mrs. B and Mr. C, and you need to find out what their normal is, because most of us do have some normal patterns that we've brought forward from our adult years. And so we need to understand what that is. But for most people, with respect to the time their body will need to do the repair and growth I talked about, it's 7 to 9 hours. And there's some recent evidence that 7 is really key with respect to cognitive abilities as well. So as we're trying to make sure we give our residents the knowledge that they need to think about how they can get their bodies healthiest, see what you can do about making sure that 7 is on your radar with respect to most of your patients. Now, the struggle is real, and the next numbers on the slide in red are where our struggle begins. And that's because in these numbers that I've put up here are normal sleep in the 65 and up population, just in general. And what you see as normal includes the 7 to 9 hours, but it also includes interruptions. And unfortunately, it's that interruptions that adds to the challenge of sleep problems in our older adults. So again, keep in mind that the normal has itself a somewhat wide range, but your patients may be on either side of that, and you really need to understand what is happening for them from a time standpoint. And let me just add this. Sometimes we ask about the hours of sleep, and if we hear something like, oh, 7, 8, we sort of maybe don't ask the next question. And I want to encourage you to ask both questions. You know, how many hours of sleep do you think you get a night? And then what are the interruptions? Because we'll talk in a minute about the natural cycle of sleep. And if there are too many interruptions, even if you were in bed for 10 hours, you may not have had 7 hours of sleep that is restorative. So I really want you to be thinking about both of those numbers. And see, now we might have 2 new vital signs to think about. So I may have to change my slide. Next slide, Amber. We've been talking quantity of sleep, and now I want to touch on issues about quality of sleep, because I kind of just alluded to it as I was talking about, you may be in bed for 9 hours, but how much of that is the quality sleep you need to be able to do the activities I talked about that happen in your deeper sleep stages. And so this picture that you see here is a comparison. On the top are 18-year-olds that have a certain sleep pattern. And on the bottom, thank you, are our 75-year-olds. And one of the areas I want you to notice is the difference in 2 very important areas. With respect to deep sleep, it's the navy blue, or maybe on your monitor, it's the darker of the blues. 18-year-olds get a lot more of the deep sleep than our 75-year-old whose eyes are open in this slide too, if you can't tell that. So less deep sleep becomes problematic. The next area to look at is the white triangle. The 18-year-old has less awake time. This is the interruptions, the that actually result in awakening you. The older, our 75-year-old gentleman has a lot more awake time compared to our 18-year-old. And then that usually means more interruptions, and that's the case. And then the other thing I do want to point out that's not necessarily detrimental, but you need to understand it, is there is a good reason why that phrase early to bed, early to rise came about. And that is that while I've mentioned the 7 to 9 hours is normal, what you may find less normal compared to how most of us maybe are heading towards bed at the 10, 11 o'clock time frame, your elders most of the time are heading there in the 8, 9, 10 o'clock is on the late side for many of them. So that by the time you add up the hours, they're also awakening a lot earlier than most of us in the 6 o'clock range. And so that's an important shift that's very natural. But within that, this is very important. The number of hours that is still needed doesn't change. So if you go to bed real early, like 8 o'clock, and you're a 7-hour sleeper, you can see you're going to be up far earlier in the morning. But what generally happens is those interruptions come. And so people end up being in bed longer than they're asleep. So you can see, I hope, why understanding these factors at an individual level is what will really help you. And it's not quite as hard as it maybe seems right now, but it does mean that you need to ask, the individual patient what their routines are and start getting that data to be able to help them. But next slide makes one of the points I wanted to make just a little bit differently. But in case this helps, certain visual people, the deep sleep is when we repair and grow and do our really restorative work. On the left in this slide, in the very bottom, is and you can see kind of outlined by the graph, are the moments in deep sleep. And our younger individual gets a lot more of that deep sleep for longer periods of time than our older adult. And so you can see that that leaves our older adult more vulnerable to not having those kinds of restorative actions, even when they're sleeping. So it becomes more additive that they're not getting that kind of repair and growth over time. And then the other piece to point out on the older gentleman is that you bump up into that awake period more often than the younger people who have the more typical fall asleep, sleep, wake up. Our older adults don't do that, of course, but that's where we can help them as we learn about ways to make even this natural inclination, right? Because I've just said this is all aging related. We can help make some of these aging related realities less impactful on people with respect to their day-to-day lives and physical well-being if we're paying attention. All right, next slide. One of the reasons we have to pay attention is that not only do we all have the effects of aging as we're aging, but many of us have other, medical conditions and things that happen to us. So in addition to sleep architecture changing, our aging aging can impact our urinary tract as well. So what I want to do now is talk a little bit about that and talk about how things change with respect to the urinary tract. We normally think very quickly, of course, of what happens to the bladder. And the number one thing that happens is it becomes less of a good storage container. It doesn't have as much capacity as it had when we were younger. And so it typically has to release urine more frequently, and it sometimes releases it when it shouldn't, which is the condition of incontinence. In addition, when we think about bladder issues, we often think, especially in men, of course, of the prostate and the changes that happen there, whether it's an enlarged prostate, which happens with aging, or an extra enlargement from benign prostatic hypertrophy or malignancy. Either of those can cause trouble with the outlet of the bladder. Well, if you've got a bladder that doesn't have as good a capacity, right, plus a prostate that's creating trouble for its outlet, you can imagine that's a recipe for trouble from the aging process. So in women, of course, there are other challenges with respect to some changes in their perineal area and vaginal area, the skin atrophying and drying and causing difficulty to their outflow. Those are all changes that can impact and make urinary incontinence more of a problem for women. The other area that I like to point out is the changes that occur in us from the standpoint of our muscle and overall strength of our physical abilities, muscular wise, with respect to the urinary tract. It's the pelvic floor muscles. And when we don't have good overall conditioning and strength, the pelvic floor muscles are the muscles that help can keep everything held up and control it and control those control sphincters of the rectum and the bladder. When that is poorly conditioned or weak, and aging can do some of that, there's less control. Now, the final area that I want to point out with respect to the urinary tract sometimes doesn't get thought of, but that's cognitive ability. So we think of the bladder and prostate and so forth because they're the part of the body that's involved most directly with urinating. But cognitive abilities and being aware of the signals, being able to do the physical activity, cognitively, that can be problematic for some of our loved ones. And so this is a large list then of things that aging alone can do to our loved ones urinary tract. If you add that on top of some of the sleep related changes I just talked about, that's where we come into some difficult areas. And on the next slide, this is where I want to overlay the concept of we've got age-related changes, and kind of when I'm thinking of a patient clinically, I'm thinking first of what we just went through. Like, this is an individual of, 75 years. What is it likely to be how is it likely to be their bladder works just baseline? Or if I'm wondering about sleep, what might be their baseline from a sleep standpoint? And then if I'm thinking about their urinary issues, because we have some urinary incontinence or nocturia, which is the next topic I want to talk about, I want you to start thinking, after you think of the age-related changes, add on top of that, now what are some of the common problems that older adults get into from other aspects? And this is where patient-centered care mattered, because what is the case for one patient will be different for another. For example, some of your patients, in this example here, we have chronic illness is one way that on top of age-related changes, you can now have more changes. Obstructive sleep apnea, interestingly, is related to higher rates of urinary incontinence. From central obstructive sleep apnea, that's an example where you can also have cognitive changes that can impact the ability to respond to the way the bladder sends signals about when to go to the bathroom. Congestive heart failure is another example, some in part related to the medications, and you see that listed. But the pathophysiology of congestive heart failure itself can sometimes lead to a vascular overload, the presence of physical edema that then at nighttime can return to the vascular system and create an increase in urinary output at night instead of during the daytime. In addition, you'll have individuals who, for other reasons than what we talked about, have other bladder conditions, that bladder stones and other problems related to childbirth, perhaps in women. So finding those additional areas of problems for people on top of the aging related conditions is important as you start to think about, well, how am I going to help this person? You kind of have to know what category of problem do they have. I think the other things I've got listed on the slides here that are worth mentioning from a medication standpoint is I've noticed in just consulting and helping people that one of the areas that we tend to miss the fact that someone's on a diuretic are the combination blood pressure medications. And so sometimes those can be part of the problem with respect to nocturia, depending on when those medications are being given. So certainly a good medication, but may or may not be for your particular patient. And then, of course, the challenge I face constantly with my older adults is the issue of fluids. I'm so anti-dehydration, but at the same time, you've got individuals who we don't want up all night going to the bathroom. And so finding the right hours in the day and the right way to get the number of ounces we need to be hydrated, that can be difficult. But if you're looking at someone with nocturia and that's an issue, then fluid intake after the dinner meal is sometimes problematic. And then I'll also point out that caffeine and other bladder irritants are an example of something that will just be added to the age-related problems of that bladder. I mentioned it has decreased capacity. Well, if you add decreased capacity and an irritated bladder, that bladder is not going to want to hold on to fluid long. So you'll be either constantly in the bathroom or starting to have incontinence. So this is kind of this is sort of the framework that I think is so important as we work to help our older residents, is thinking over how does age change us and how does this individual's particular health history impact the problem I'm facing. On the next slide, I've shown a breakdown of urinary incontinence. This is chronic urinary incontinence, actually. And what I want to point out here, and we're not going to go into this in much length here today, but what I wanted to point out is the far left side of this slide. And that's where I've bracketed all of the other causes under the heading multifactorial, because I really want to encourage you, as you're thinking about helping someone with urinary incontinence, to not close the book after you've got one answer. So even someone who you've just diagnosed a urinary tract infection in, that's important to know that could be the cause. But be careful about then presuming all will go back to, everything will be completely resolved after we treat the urinary infection. Very often, if you're talking about an individual in a residential setting, and especially if it's skilled care, very often most people in that setting are going to have this multifactorial, and they're going to have other aspects. Very often, that's why it's at the top, functional problems with functional problems with mobility or dexterity or cognition that impact their ability to manage and control their urinary stream like they used to. And without that ability to manage and control it, that's where the condition of urinary incontinence comes in very often. So keep in mind the multifactorial nature of urinary incontinence if you're facing that and trying to work with it. Okay, the next slide. Great. So what I want to do next is talk a little bit. This is still the doom and gloom part of the talk. I promise we're going to get to some positive vibes on some solutions, but I still unfortunately have some bad information to share about what sleep deprivation does to us over when it's chronic, and why, again, if it's due to nocturia or urinary incontinence, we really want to be doing something about it. So next slide, Amber. Yeah, so the bad news about, so now nocturia and urinary incontinence, what they're doing, and now you know how problematic this is. They are some of the main causes of sleep disruption. Now, I know there's like a chicken or which came first kind of discussion, and I get it, but I sometimes say, I don't care if they're disturbed, they're disturbed. If their sleep's interrupted, their sleep's interrupted. Whichever, whether they got up because of the need to urinate, or they got up because their undergarment was wet, or they just woke up and then thought they had to go to the bathroom. I'm ambivalent, or I'm agnostic to that. I just am concerned that their sleep is interrupted. And so if you're in that vicinity, you really got to look into that, because once that happens, they become a chronically sleep deprived person. And if any of you have been chronically sleep deprived, it is not a healthy state. And it should not be allowed to go on for a long time, but it does. But when it does, it's really chronic insomnia. It's got disease categories in my coding book for my doctor's visits. So it is a problem, and it encompasses all the things we've touched on with respect to, poor physical status, poor physical mobility, poor physical strength. We talked about that. The issues from a quality of life standpoint having to do with less activity, depression, mood problems, anxiety, all of that. There is an increase in all of those problems, those negative sort of life, quality of life aspects can come from the chronic sleep deprivation that can be related to these problems. The facts of that are very clear. I appreciate that the solutions are far more challenging than we'd like them to be for something that is this clearly connected. And we know what's causing it, but now we have to do some fixing of it. So in the next slide, I promised we were going to get to some positive solutions. And that's really where I want to go, because as we think of our solutions, I want you to, we put a picture of a person here because we really want you to take this at this very personal level and think through, the quality of life impacts of these sorts of problems, some of which are physical, some are emotional, some are social, having to do with, not wanting to leave your room or being afraid to be close to anyone because of the potential that they can detect an odor. There are all sorts of problems that individuals who have these challenges face. And I'm really excited, I'm really encouraged that we're having these discussions so that we can provide some relief to people. I also appreciate, and that's where the second bullet is added, because it mentions that the nihilism, I think, is a fair word. We've used stigma before when talking about this topic. There is a lot of that in regards to this problem. And I would just encourage you to think about what we've talked about here. And as we talk about some solutions, just keep it, just open your mind to this reality that if you understand what is happening, there are some directed solutions that have pretty good potential to help reduce, if not eliminate, but to reduce the impacts of urinary incontinence, be it during the day or at night, and the potential that you can restore some of that, those deficits that I've been describing are great. And so I think while I know it's a tough area to even contemplate working in, I hope we're going to give you some encouraging reasons to know that you can do it and make a difference for people. So, because we want this gal smiling, not looking quite so distressed by her need to be or her interest in being up and about, but finding it difficult. So, all right. So let's go to the next slide. And this is where I promised we would get positive. So this is where we're going to be a little more positive, because I'm really hoping, ultimately we're talking about this with regards to sleep. So we really do want to see if we can make an impact on improving people's overnight. But as we've said, it's a little bit of a cycle, isn't it? So it's all connected. So we'll talk about some nighttime specific, but we're going to talk about some just general specific strategies as well. So on the next slide. Good. I wanted to start with, we're going to talk really kind of nocturia and urinary incontinence and how it impacting sleep and some things you can do about it. So with respect to nocturia, I put it in a bigger font and bold because I can't emphasize enough. Talk to the patient, find out why the nocturia. I can't tell you enough that it, just like urinary incontinence in general, we sometimes believe that it is probably an inevitability of aging. And I will admit that there is a high likelihood that many older adults will have some amount of urinary incontinence. I understand that. We just got done talking about that. But I hope you also saw there's a lot of mitigating factors and issues that are at play that culminate in that urinary incontinence. And if we can find some of those modifiable factors, there's evidence that you can make a change and decrease some of the negative impact, if not eliminate it. If you can't eliminate it, and I think there are some times when you can't completely eliminate it, but I think there is a lot of good evidence that you can reduce some. And then we'll talk in just a little bit too about if you can't eliminate it, then let's make sure we're managing it really, really as well as we can. So definitely start asking some questions and find out. Statistics will tell you the fluid is going to be one of the biggest things. So again, Sips after 6 is kind of our rule around our clinic, and it can be difficult sometimes. But even with medication passes that are being done later, you can do, sips. And what this means, though, is especially in the more frail of our loved ones, we need to be thinking about making sure their hydration is met well before 6 p.m. And that can sometimes mean, differences from a dietary standpoint. It can sometimes mean differences in having care aids available to make sure people are getting toileted. So there are implications for this, but it's really important to be thinking through, if we're going to cut the fluids off at the 6 p.m. mark, have we provided enough throughout the course of the day? And so I think I want to make that point. I've mentioned the caffeine, and that's a really important one. And most of the time these days, you can get most people to switch to something decaffeinated, which is good. And I probably should put up their carbonation, because that's another irritant that some people realize, or that some people are affected by more than others. And then the salt intake. Salt is an edema producer. And so salt intake is an edema producer. So if you have someone who's in that situation, and this is where you've got to sort of make these patient-centered sort of inquiries to be able to know, does this individual, perhaps more than someone else, need more of a low salt intake? And so that can be important. So keep an eye on that. Now, with respect to chronic conditions, these are difficult, but I want to just put out a couple of strategies that can help with nocturia. So again, we're trying to really reduce the number of times someone might need to get up to go to the bathroom at night. First things first, with people who have chronic lower extremity edema, you're probably familiar with the phenomenon when they are dependent all day and the edema is dependent down in their lower extremities. When they then become supine without the effects of gravity, the physiology is such that they are often able, just from the physical force, able to move more fluid into their circulating vascular system. Well, what that does is it says, hey, I didn't know this fluid was all here. And it starts the process of hitting the kidneys and becoming made into urine. So the storage of the fluid was in these dependent legs all night. And now that they're supine, it's going to dump into the kidneys, and voila, you have to get up to go to the bathroom, perhaps a couple of times. I've seen this create probably on order of 1 to 2 needed trips at night. From most cases of peripheral edema. So one potential strategy for that is to have the individual, especially if these are individuals for whom the compression stockings aren't an option, have them have a dedicated rest in the afternoon, or a dedicated period in the afternoon of about 2 hours, if possible, where their legs are elevated. And you all know they have to be, elevated. So up a little bit more than just at the, level that they would be with supine. And that can sometimes be difficult. You got to be creative with pillows and cushions and make sure the rest of their body doesn't feel the ill effects or feel any ill effects from that. But that can be a good strategy to kind of have some of that diuresis happen before they're trying to sleep at night. So sometimes that's helpful. I mentioned obstructive sleep apnea earlier, and there's some interesting information about having sufficient sleep apnea treatment of about 4 hours is one of the markers that is starting to be known to show benefit for the sleep apnea itself. And it's presumed it will have benefit for the effects of the sleep apnea, which I mentioned is the potential for increasing nocturia. So that's why the recommendation for having the CPAP or whatever remedy you're using for your sleep apnea, have it on at least 4 hours if at all possible. And I know that's a challenge in some situations, but sometimes knowing that they don't have to have it on all night maybe just 4 hours, sometimes that's enough to get some of the patients to agree to use it. I've seen that happen. So knowing that you can make it, that it's still worthwhile at that 4-hour mark can sometimes be good. With congestive heart failure, if there are times when you'll see regimens for people with congestive heart failure and they have a twice-a-day dosing. So, and sometimes it's necessary, in part because of what we just talked about. If someone's in a state where they simply can't manage their total fluid volume, you really just have to get a certain amount of fluid off of their system during the day so that at night they're not completely overwhelmed by that. Because for some people, even though the fluid would be coming into the system, the kidney isn't able to keep up. So in those situations, often people will have a second dose of the diuretic in the afternoon. Well, the closer you get that to dinner time, the worse it is. So you may want to talk to your providers about moving that even to 2 o'clock or some earlier pastime so that you can have the individual, like I said earlier, kind of manage your fluid load during the day so that you're able to not have to be managing or manipulating a lot of fluid in the evening. And that can be a big help to people. It's not a good idea to put the whole dose at once. And typically that's because you probably can understand that sometimes it's just too much of a load on an individual. So it's unfortunate, but because you need to get rid of a certain amount of fluid, but you have to do it at certain times. You can't do it sort of, all at once. The body doesn't keep up very well with that, especially our older bodies. So, and then, GERD, the gastroesophageal reflux, is another reason for common interruptions. Then this one is sort of implicated in the once you're awake, then do you have to go to the bathroom sort of issue. I don't know, but I don't like it. So we talk about making sure you get the head of the bed raised, and not just the head, kind of the sort of what you're trying to raise is the chest, not just the neck. So I'm imagine many of you are familiar with that, but you really do want to elevate the chest, basically. All right, I think those are the main things on this slide. Amber, we can probably move to the next one. The other sort of 2 areas that I want to mention on the nocturia have to do with the possibility of someone getting benefit from what's called double voiding. So in general, you can do double voiding very simply by having 2 different times within maybe 5 minutes of each other that someone voids. Most of the time, older men are going to be better off voiding sitting down. But that's not everybody, and you can make sure you find out from a patient-centered standpoint if you've got someone who really has trouble voiding sitting down. But many times the older gentlemen are going to do better sitting down. It sometimes takes some getting used to, but that's often the case. And sometimes the ability to know if you've emptied your bladder is not there. So the double voiding is actually a way that you don't have to rely on someone knowing if their bladder is fully empty. So this strategy is especially good for people with any cognitive impairment, because they'll get used to you asking them to, or they'll get used to sitting down and going to the bathroom. So doing it again 5 minutes later, it doesn't matter if they're perceiving it or not, they'll be used to, and they can often try again, and often you'll have a little bit more released. For some women, the leaning slightly forward is specifically important for women when there are any kind of prolapse with respect to if they still have all their pelvic organs. That's especially important. And women can sometimes not even realize or know that they need to make that adjustment to improve the emptying of the bladder. And then finally, for some men, the handheld urinal can be very useful. Some of them like to stand up, others sit on the side of the bed, but that can be helpful so that they're able to empty their bladder, but they're not as interrupted and get back to sleep sooner. Other people, the bedside commode is a similar, benefit to a slightly less of an interruption, if you will. All right, I think we better go on to the next slide, Amber. Now, this is where we have got individuals with urinary incontinence, and I think it's been, I think, distributed alongside this presentation are two handouts, and this first PDF is a generally good handout. But one thing I want you to know is before you get to the handout, you got to do step one. And what I really like about working with Seni is that their overall goal is people have less urinary incontinence. And I like that goal because, as we said before, less urinary incontinence is what we all want for everybody. And so no matter what you're doing to help someone, I just kind of like when I said for nocturia, find out why. Well, if you're helping someone, especially who's having overnight urinary incontinence, please do everything you can to find out why. Think about that multifactorial list we talked about and try to reduce it, because everything is going to be better for people if we can reduce their urinary incontinence. And there's good evidence that some of the things we're talking about right now can do that. If you've gotten some reduction from things you've identified, but you still have someone who has urinary incontinence, especially at night, that's when I really want you to think through a patient-centered approach. And the questions on this handout are kind of at the heart of a patient-centered approach to what time do you normally go to sleep? What time would you normally need to have your brief changed that it's getting wet? What time are you usually getting up in the morning? This handout is sort of created so that you can think through, what does this resident need with respect to what's happening to them and most nights, and how we can help them. And so after you go through the questions, sort of identifying what this person needs, there's some ability to think through, well, what kind of product, if they need a product, what kind of product would help? Or can we do other things that are related to, like Kegel exercises? That's a whole nother discussion, but I can't do a talk here without saying the word Kegel exercises. And anyone who's skeptical, do look it up. Kegel exercises have a wonderful success rate, even among frail elders and among men. So that's a very valuable part of this sort of very comprehensive patient-centered approach. If you do need a product, there's also some information on a second PDF, and we may see it here in a minute. But what I want to on the next slide, I think the next slide is where, this, as you go through, if you've got an individual with urinary incontinence creating sleep disturbance, I really want you to think about this concept of knowing what their sleep pattern is, knowing what their incontinence pattern is, putting those two together and seeing what you can do to see what you can do to help someone sleep more, even if you have done everything you can to reduce their incontinence and they still have some. Okay, that's fine. Let's get them a product, an undergarment that they can wear that will protect their skin, that will be as absorptive as possible, that they can sleep longer while still having their skin protected. That has to do with how well the product removes the fluid or the moisture from the skin layer, right? Well, there's products nowadays that are much better at doing that. And so I would encourage you to kind of re-up your knowledge of products. I know it was eye-opening for me. There's even an ability of the product, and that's what's depicted here, to give you a color indication to let you know if the product has moisture in it and potentially needs to be changed versus it doesn't, and someone can keep sleeping. So that can be a sea change for some of your patients who, because of factors, age, illness, medication, what have you, they're going to have incontinence. Okay, fine. Well, then let's go to the next step and see what we can do to manage it. And maybe they too can still get a little more sleep out of their night. Next slide. Thanks. And this was the second PDF that I mentioned, and I really do like this concept of daytime, nighttime, and remembering that it's all a cycle. And there's some information on here that talks about the fact that what product works is best for daytime may not be best for the nighttime. And so I think that's another example where you really want to find out from what your patient's needs are, and take the time to find out that you have the right product at the right size product. And just the other day, I had an individual who's very, very petite, and so they were leaking. Well, I thought leaking because there was too much fluid, like the product couldn't absorb it all. Well, no, the answer was they were leaking because they were so petite. Even the undergarment was too loose, and there was no real, protection, if you will. There was no sort of, it was just all leaking. It wasn't full though. So, that's a good example where we wanted to sort of, improve our product selection for that individual, and it has certainly helped. All right, so I love that they've got a little bow on this, these PDFs, because I do think that the gift of sleep is something that perhaps after what we've talked about here today, you can give to some of your residents who are struggling with this. So, and maybe start using a vital sign around your facility of how much sleep is everyone getting and how many interruptions are they having, and decide to maybe start looking a little bit more into that for some of the individuals whose numbers don't look right in that respect. So thank you. Last slide, Amber. I guess that was there we go. And I think Kristen's gonna take over from here.
Yes, thank you, Dr. Laird. So Kristen, can you share about your experience with the gift of Cine products?
Sure. So it was very educational. When Patty came in from Senny, we did the assessment form, and then we were able to pick, 3 elders, and one of my floors that I felt specific people that I did choose that have some incontinence and some issues going on. So I thought that was very informative. Anything geared toward patient-centered care here in the Woodlands is great. Anything educational to the staff, and of course, feedback from the Shabazims here would be the best part, because they are with the elders more than anyone. So I found that it was great. We did the elder incontinence form. We filled it out. We did measurements, got their size. I thought it was very informative to find out, because visually we think, oh, she's petite, she's small, we'll get her a smaller and extra small. So it did turn out to be really educational in that part, because the ladies that we thought were really small, after we measured them, they kind of had some hips there. So I think that adds to a lot of issues too, with leakage and not being able to sleep, and skin, breakdown of the skin, and having to change them more often. I think those were a lot of factors that I learned a lot about as well. So learning the incontinence level, the product type, what was preferred by the elder. So all those things we took into consideration, I thought were really great and informative. We also did the pre-trial survey too. So I was in charge of doing all the the elder assessment, and then the pre-trial, and then of course the product trial survey afterwards. So the pre-trial, turned out to be pretty interesting as well. So basically what we did was we got a month's supply of Senny product here. Patty had it sent. I distributed it first to the home where we chose the 3 elders to do the assessment form. So when I passed everything out, Patty came in, we spoke with the staff to let them know, here's the product, here's what we're going to be doing. So we monitored the staff and everyone before, the form, we did that. And then when we dispersed everything out and it started to being used, actually the product really sold itself. You know, coming from a background in sales and marketing and home health and my whole career in sales, you always want to be passionate about what you're selling or what you're educating on. And this product really sold itself, which I was quite surprised. The staff started saying, wow, you know, where this stuff is great. Are we going to be getting it? Everywhere from the briefs to the creams, every product that they gave us to, you know, the wipes, everybody was just boasting and bragging about it. So, you know, it made my part easy, actually. So that's how we figured everything out. And then I had dispersed some extra on another floor that wasn't on the trial. And they were coming to me. People were like, can you get me some more of those briefs, the chucks, you know, the lotions, the wipes, everything. So it really sold itself. And we did see a lot of less changing. Skin breakdown got a lot better. We had one lady who, with our product that we had here, was having some allergies to what she was wearing. She was getting skin allergies. We actually she was small, so we actually ordered some extra smalls for her, and the skin irritation stopped. So that also sold itself as well. So we ended up just getting really great feedback. And then when we did the product trial survey, you know, I think there was like 7 or 8 questions, and I pretty much answered everything that I strongly agreed because of the feedback from the staff. So we actually got John Knox in Pompano with the help of, you know, Deanna and Patty. We got a John Knox to change their old supplier to Seni. So we're very happy.
And so Christian, can you just slide your camera open so we can see you?
Oh, I'm sorry, I closed it before.
Oh, that's okay.
See me now?
Oh, it's black again.
Oh, is it? Hold on.
Yeah. So there's actually there's a couple other organizations that are trialing the product as well, and one in New York and another one in California, and we're expecting similar results that John Knox Village had. So I'm seeing we only have a couple more minutes left, and there are a couple questions. So one of the questions came in early. If you're a family member, how do you change in an assisted living facility and does not even consider the connection between sleep and incontinence? So Dr. Laird, what would your wisdom be for this attendee?
I think that the first thing I would do if I were a family member is what I try to tell all families is to establish early on that you are an attentive, loving caregiver, and that you are looking forward to, you know, working with the team at the facility, and you're thankful and appreciative of them caring for your loved one. Having a good foundation of a relationship then helps when issues come up. So I think that's kind of, and if there's challenges in that respect, I know that can be the case, but very often if there's a social worker or someone outside of the nursing staff at the facility you can talk with about getting sort of making sure you know what the avenue is at that facility for talking about concerns, that sometimes is important too. But with respect to the sleeping in particular and urinary incontinence, I think I would what I tend to recommend families do as well is use the format of asking questions of the team, and instead of sort of like expect or requesting actions. So meaning ask questions. How is my loved one sleeping at night? How many hours do you think of sleep they're getting? I've been told sleep is important. Do you know how many hours? Ask that question. How many times might they be awake at night? And sometimes your interest in that form of a question is met in, hopefully, in a respectful and appropriate way by the staff you're talking with. And that will often tip them off to the fact that you're asking that question, and you can start seeing what the answers are and inquiring. If you don't hear the answers, like we just talked about today, you can ask for more in-depth assessment. You know, maybe we could watch for a week and check, and hopefully you also have a provider, primary care or nurse practitioner or someone else that you can also enlist in your questions about sleep and incontinence. And that would be my two advice. So try to have a good relationship to start, and or foster a good relationship, and use questions to explore areas that are concerned about, that you're concerned about. And the final, of course, is every facility has a director of nursing. And I think ultimately, if you have a concern about your loved one's care, that would be the place I would recommend you take it. And I would hope they'd be open to this kind of a suggestion.
Yeah, thank you, Dr. Laird. And Deanna, do you want to share a little bit about opportunities for other organizations to do a trial of the Cine products? You're on mute.
Thank you. Thanks, Carol. Yeah, I would just encourage anybody who may be working with a resident that may be challenged with incontinence, or a patient or a client or a loved one or a family member. We would be more than happy to provide free product samples, or a similar trial to what we did with John Knox and what we're doing with the others, where if you want to pick out 3 or 4 residents, we always say your most challenged residents with incontinence is what we encourage, because really, as Kristen had alluded to, the product tends to sell themselves. So we're certainly open to that, and please reach out to us. We just feel seeing is believing, and we know too, with communities change, with staff and schedules and policies, there's a lot to it. So things sometimes can take time for a whole community to change, but even one resident that we can help that's challenged, we can help that resident today with free product samples. So we absolutely encourage it, and we'd be more than happy to help.
Thanks so much. So we are beyond the top of the hour, and we still have several questions in the Q&A, but we will address those questions and get them back to you via email if we have your name. There's one that says anonymous, so it's harder to get back to that person. But if there are if there are people that want to stay on for a couple minutes for some conversation, we'll be happy to do that. But thanks so much for your attendance today.
Thank you.
And Carol,
Yes.
I unfortunately have to go. So,
Yeah.
but I'm happy to help Deanna with answering questions.
Okay.
Okay.
Yeah, so there's an Alice Rose that has a question. Thank you, Dr. Laird.
Okay.
I appreciate it.
You're
Thanks.
welcome. Merry Christmas and Happy New Year to everybody. Bye.
Thank you. Alice, you had a question? You can unmute and ask it.
Carol, I'm not sure they have the ability to unmute.
Oh, okay. I have a button that says ask to unmute.
Okay.
But I don't think we're gonna be able to. Although I'm trying to get to her, I don't know that we can. She's in our box.
Yeah.
Hey,
Yep.
Dr. Laird did a wonderful job as always, as did Kristen.
Yeah, real appreciative, as did you and Janet and everybody. I always say it takes a